All right, good morning, everyone. It's 7 a.m. So I think I'll go ahead and get started. My name is Sana. I'm one of the first year Allergy and Immunology fellows here over at UW. Today I'm going to be speaking with you about biologic therapies that are used for the treatment of asthma. I do not have any disclosures. My goals today are first to define the patient population that we'll be using these therapies in, which means understanding asthma and its spectrum, especially severe asthma. I'm going to be reviewing the underlying molecular pathophysiology of asthma. We'll also need to understand asthma endotypes and phenotypes, as well as how to characterize patients. And then we'll review the available biologic therapies and ways to think about selecting a treatment strategy that's right for an individual patient. So first off, what is asthma? It's hard to get a concise definition of asthma, and I think that's because we realize that it's more of an umbrella term for a variety of clinical presentations. But we can all agree that asthma is a chronic condition which has specific symptoms. These symptoms are variable and often episodic, and patients have, in most cases, reversible expiratory obstruction due to a combination of inflammation, bronchospasm, and mucus production.
Hey, Sana, sorry to interrupt.
Yeah.
We're seeing the presenter view, which is fine.
No, but I can switch that. Is that
perfect?
Okay,
Thanks.
Great. When I practiced yesterday, it was like the other way around. Okay, so asthma affects more than 300 million people worldwide, and affecting approximately 8% of the US population, which comes out to about 25 million people in the US. In Washington specifically, asthma prevalence is at about 10% as of 2019 per CDC data, which is affecting 590,000 people in the state, most of those over the age of 18. Asthma does not treat everyone equally. There are clear demographic risk factors for severe asthma, such as low income status. There's one study I saw that showed a higher prevalence of asthma in patients with Medicare and Medicaid insurance versus those on private insurance. Other risk factors include the female sex, and asthma disproportionately affects Black American and those with Puerto Rican heritage. Approximately 5 to 10% of asthmatics are defined as having severe asthma, which I'll define further in a few slides for you. A separate issue that we'll also talk about a lot is asthma control, and the CDC data suggests that over half of Americans have uncontrolled or poorly controlled asthma, with this figure here from the CDC showing the data that they have on that by state. If we were to create a Venn diagram, we would then find a small subset of patients that have truly severe uncontrolled asthma. And it's hard to know exactly how many patients fall into this group. The GINA guideline cites a figure of about 3.6% of patients with asthma having severe uncontrolled asthma. This figure comes from a study of a Dutch population, and it is hard to know exactly how much that maps onto our specific patient population, but it does give us a sense of the range. So we know that this is a relatively small proportion of the patients with asthma that we are treating, but they are responsible for a lot of the morbidity and a lot of the cost of asthma. Asthma is very expensive. It has a huge impact on patients' quality of life and their ability to lead a productive life. And there are many expensive treatments, especially as you escalate therapy. And there's a huge cost of asthma exacerbations with their associated ED visits, hospitalizations, and ICU stays. This figure here shows us from a study that's showing the per capita cost of asthma by state in the year 2012 for those affected by asthma. In 2012, the estimated cost of asthma in the state of Washington was $732 million, coming out to about $1,000 per person who is affected by asthma. In 2018, there were over 1.6 million ED visits for asthma, and over 180,000 asthma stays. And we can't forget that despite our best efforts, asthma also carries a huge mortality burden, which has been unfortunately led to the demise of about over 3,000 Americans a year, affecting, coming out to a rate of about 10 deaths per million US population annually. So as we're here to discuss biologics today, we are in most cases grappling with severe asthma, though we're starting to reach for these therapies in patients with moderate asthma as well. There are several definitions out there of what severe asthma is, and we're all familiar with charts based on symptom frequency and nighttime symptoms and rescue inhaler use. But I do like this definition of asthma from the GINA guidelines, which defines severe asthma as that which is not controlled despite high-dose ICS-LABA therapy or that requires high-dose ICS-LABA therapy in order to maintain control. And what does it mean to have symptom control? This is one of the major axes that we're thinking about when we're assessing our patients with asthma, and we're continuously measuring symptom control over time as one component of our overall assessment of them in conjunction with their general health, PFTs, and physical exam. This is a tool that GINA has to assess asthma control using a combination of symptom frequency, overnight symptoms, use of reliever medications, and activity limitation. But there are many validated options out there that are easy to incorporate in clinical practice, and these are questions we're always asking our patients with asthma. One other tool that's out there that we commonly use is the asthma control test. And for pediatric patients, there's a modified childhood version. It gives patients a score based on 5 questions that categorizes their asthma as well controlled, poorly controlled, or not controlled. Their asthma control questionnaire also has 5 questions that reports a probability that the patient's asthma is well controlled in a gray zone or poorly controlled. There's also an ACQ 6 and 7, which are not validated, but do collect more information by asking about SABA use and pre-bronchodilator FEV1 respectively. What we're really trying to do with all these categories and screeners is to identify those who are at high risk of acute exacerbation and may need more aggressive management. One thing to keep in mind is that poor asthma control is not the only risk factor, and that other risk factors are associated with exacerbations, even in patients who don't have many symptoms. Up to 1/3 of patients who have an acute exacerbation and up to 20% of those who have a fatal exacerbation had symptoms less than once a week in the months prior to the event. So asthma control is not the only thing that we can focus on in identifying our high-risk patients. High SABA use is a risk factor and is particularly associated with an increased risk of mortality in patients who are using more than one 200-dose canister a month. We also worry about patients who are not compliant with their inhaled corticosteroid or have only been prescribed albuterol so far. It's critical to ask also about other medical history, such as obesity, sleep apnea, history of food allergy, which all raise the risk of asthma exacerbations. And we keep a particular ear out for factors that can be modified, which may need referrals to other subspecialists, as well as help from the primary care physician. One of those factors in our domain is allergen exposure for those who are sensitized, which we can manage or even treat. We also need to keep a close eye on patients who have significant obstruction or airway inflammation as evidenced on their pulmonary function testing, or those who have PFTs that show a high amount of reversibility with bronchodilators. And then of course, the past predicts the future. So we also want to make sure to ask about past exacerbations and particularly needs for intubation or ICU stay to give you a sense of their severity. And we're gathering all this clinical information in order to help us start our treatment plan along some point along this ladder. I'm sure all of you are very familiar with this proposition from GINA. We start at the first few steps, just managing symptoms as needed with ideally an ICS-LABA per the new GINA guidelines as of 2019. By step 3, we're also adding on maintenance ICS-LABA, and we can increase the dose if we need to. We choose a place to start, and then we may need to move up the ladder, maybe with or without a leukotriene receptor antagonist. And along the way, we're also doing more workup for our patients. We'll focus in a bit about the diagnostic workup that assists us in categorizing a patient's asthma phenotype and endotype. But globally, just to review, we need to make sure that the patients have optimized medication adherence and technique, that we're thinking about other medications they're on, such as beta blockers or NSAIDs that could be contributing. We're evaluating tobacco use, making sure they're screened for COPD, sleep apnea, vocal cord dysfunction, occupational environmental exposures, and keeping our differential broad for other things such as EGPA or ABPA that could be contributing. And as we're doing all of this, we're also preparing for the next step in treatment of our patients. So for those who are not controlled despite high-dose ICS LABA therapy, what can we do to get them under good control? So that brings us to step 5 of this ladder. Looking at this a little bit more closely, we have multiple options, but before we get there, we need to be assessing the asthma phenotype of the patient. And so let's talk a bit more about what that means. In order to tailor treatment, we need to understand phenotypes and endotypes. Asthma is a heterogeneous disease, and as we discussed before, really more of an umbrella term. There are different asthma phenotypes that have been well described. And a phenotype is more about the observable characteristics that have a combination of hereditary and environmental inputs leading to a particular phenotype. It has features that we can identify in the clinical presentation and the patient's physiology, such as the young atopic patient or the adult with aspirin sensitivity and nasal polyps. As we move into the molecular age, though, we're drawing our attention more and more to patients' endotypes, which are distinguished by the immunopathologic mechanisms that are driving their disease. So let's talk about what's going on at a molecular and cellular level. In general, we have a variety of different insults to the airway epithelium that initiates an inflammatory response. First, many of our patients have an allergy-driven component to their airway inflammation. An antigen-presenting cell can show an allergen to naive T cells, and the antigen-presenting cells are also promoted activity by the alarmins, which I'll talk about in a moment. The activated helper T cell then most often skews towards a type 2 phenotype, which then produces IL-4, IL-5, and IL-13. IL-4 promotes B cell class switching, leading to IgE production, and then IgE then activates mast cells and basophils to degranulate and cause inflammation. IL-5 is a cytokine that promotes eosinophil activity and survival and maturation, and promotes eosinophilic inflammation. And then IL-13 largely acts directly on the airways to promote goblet cell hyperplasia, mucus hypersecretion, and smooth muscle hypertrophy, which all lead to airway inflammation and hyperresponsiveness. Other triggers that are non-allergic, such as infections or smoke, other pollutants, can also cause epithelial damage, causing release of the alarmins by the airway epithelial cells. IL-25, IL-33, and TSLP are the ones we're most familiar with. And these alarmins activate innate lymphoid cells, the type 2 cells, which then also produce IL-5 and IL-13, leading to the eosinophil activation and airway effects of IL-13. This pathway does not promote as much IL-4 production, and so there really isn't a component of the IgE-mediated inflammation. And this pathway of this type of type 2 inflammation may be more implicated in other types of inflammation, such as the patient with nasal polyps and aspirin sensitivity. In other patients still, this same process, for whatever reason, rather than promoting a type 2 inflammation, leads to differentiation of Th1 and Th17 cells that generally activate neutrophilic inflammation. And this process, unfortunately, is not nearly as well understood as the type 2 inflammation. So at this time, our understanding of endotypes is largely in these two categories, type 2 or non-type 2, which also referred to as T2 high or T2 low asthma, I'm sure with time, as we gain more understanding of these pathways, we'll become more granular into how we divide our patients. T2 high asthma is associated with the Th2 and ILC2 cell activation, as I just reviewed, leading to IgE production and eosinophilia, something that both the young atopic and the adult with nasal polyps have in common. Non-allergic asthma seems to be driven by those who skew to a Th1 and Th17 phenotype, which promotes neutrophilic inflammation. Sputum cytology of T2 low patients can also be polygranulocytic. The pheno is often normal due to a lack of eosinophilic inflammation, and these patients tend to be less responsive to oral corticosteroids. This could be a category of asthma that is associated with obesity or onset in the elderly, but we're really only just starting to understand how our familiar asthma phenotypes play in at the deeper level of the endotype. Part of our evaluation for patients with severe asthma includes biomarkers to characterize our patient's endotype. We know that both the Th2 and ILC2s produce IL-5 promoting eosinophils. So one of our best markers for type 2 inflammation is sputum cytology showing over 2% eosinophils, which is a direct reflector of eosinophil recruitment in the airway. Sputum is often a bit more difficult to get than eosinophil counts from the peripheral blood, which is often what we do to get by. But this may not be as sensitive or reflective of what's going on in the airway, especially for patients who are on oral corticosteroids. We usually use counts of 150 or 300 as cutoffs for peripheral eosinophilia in this regard. Another marker of type 2 airway inflammation is the pheno. Nitric oxide is produced by airway epithelium, eosinophils, and macrophages, and IL-4 and IL-13 activity promote increased nitric oxide production. A level above 50 is most consistent with eosinophilic airway inflammation, but GINA guidelines use a benchmark above 20 to be considering type 2 inflammation in a patient. We also are interested in knowing the total IgE level as well as aeroallergen testing, which can help us to identify patients with allergic asthma. This evaluation should be repeated multiple times if it's initially negative. Some guidelines suggest up to 3 times, as findings can be dynamic over time, especially in patients who are on oral corticosteroids. Ideally, we can try to do our best to get them on the lowest dose before doing this evaluation. And the reason that we are so meticulous about doing this workup multiple times is that we really want to capture all of our patients with type 2 inflammation, because those are the ones we have the most treatment options for. So that brings us back here. Once we've done our phenotypic assessment and we can say that our patient has T2 high asthma, we're ready to think about adding on a biologic therapy. So without further ado, let's discuss the FDA-approved biologics used in the treatment of asthma. Here is another figure that is outlining the pathways mediating type 2 airway inflammation, showing the alarmins activating the ILC2s and the naive T cells into Th2 cells, leading to IL-4, IL-5, and IL-13 production. At this time, we only have the biologics available for T2 asthma that focus right now on IgE, IL-5, and IL-4 and 13 signaling. For T2 low patients, there are no current FDA-approved biologics. We have other therapies such as antimuscarinics, azithromycin for anti-inflammatory effects, but these aren't the focus of our discussion today. The first biologic that was approved for the treatment of severe asthma targets IgE, which activates mast cells and basophils, causing airway inflammation. Omalizumab is the monoclonal antibody which binds the Fc portion of circulating IgE, leading to decreased levels of IgE in the blood and preventing their binding to mast cells and basophils, which you'll recall is drives airway inflammation after aeroallergen exposure. So naturally, it's used in patients with an allergic component to their asthma. So it was FDA approved in 2013 for severe asthmatics in patients age 12 and up. And in 2016, it was approved down to the age of 6 and also expanded to include patients with moderate asthma. In order to be eligible, patients have to have uncontrolled symptoms on conventional therapy and also have evidence of sensitization to a perennial aeroallergen such as dust mite, pet dander, or mold. It's given subcutaneously, and the dose and frequency is dependent on the patient's weight and their pretreatment IgE level, starting at a lower limit of 30. It can be transitioned to at-home therapy, but this should be done very selectively, as there is a black box warning for anaphylaxis for omalizumab. It is also approved for use in chronic spontaneous urticaria and nasal polyps, so it's important to kind of keep in mind your patient's comorbidities to see whether there's other things you can treat with just one drug. The initial phase 3 randomized controlled trial for omalizumab showed a reduction in the rate of asthma exacerbations by 25% compared to placebo. And there have been other studies since then that have suggested perhaps even greater efficacy in reducing asthma exacerbations, especially in patients with higher eosinophil counts and FeNO. The GINA guidelines suggest an AEC above 260 and a FeNO above 20 as markers for patients that are most likely to benefit from omalizumab. Studies have shown that a baseline IgE level is not shown to be a predictor of good response to the drug. Overall response rates seem to be between 30 and 60%, and typically you should give the patient at least a 3 to 6 month trial before deciding whether they have responded. As I mentioned, it has a black box warning for anaphylaxis, and anaphylactic events can occur even up to 1 year after initiating the drug. So while it is approved for home use, this should be reserved for very low risk patients who are prepared to recognize and treat symptoms of anaphylaxis. Injection site reactions such as bruising, redness, warmth, high formation are very common, and arthralgias and headaches are also common symptoms as side effects for this drug. Next, we'll discuss therapies that focus on the IL-5 pathway with 2 drugs that are targeting IL-5 directly and one that's binding the IL-5 receptor. Mepolizumab was the first drug that was approved in this category. It's a recombinant humanized monoclonal antibody which targets the alpha subunit of IL-5, preventing its binding from the IL-5 receptor. It is approved for add-on therapy in patients with uncontrolled eosinophilic asthma that are 6 and up. There is no specific eosinophil count that is required by the FDA to qualify for this drug, so it's up to an individual provider to use their determination of how to categorize the patient as eosinophilic using a combination of sputum cytology, peripheral blood counts, and the FeNO. Many use a cutoff of at least an AEC at least 150 at the time of initiating therapy and above 300 sometime in the past year. Poor asthma control is often demonstrated by the number of exacerbations in the past year. Mepolizumab has a standard dosing of 100 milligrams every 4 weeks given subcutaneously, and for patients above the age of 12, the at-home therapy is available. It's also used for treatment of hypereosinophilic syndrome, EGPA, and chronic rhinosinusitis with nasal polyps. In a phase 2 randomized controlled trial for mepolizumab, which was conducted in patients with more than 2 exacerbations in the past year and evidence of eosinophilic airway inflammation, mepolizumab just demonstrated a decrease in asthma exacerbations by 50%. And similar results were seen in multiple other randomized controlled trials. In the Sirius study, which was focusing on the outcome of oral glucocorticoid reduction, oral steroid-dependent patients with an eosinophilic asthma were treated with mepolizumab. They were found to be 2.4 times more likely to reduce their steroid dose compared to the placebo group. And in the treatment group, the mean reduction of oral steroid dose was 50%, whereas there was no change in the dose in the control group. All while the treatment group maintained their asthma control and had a exacerbation rate reduced by 32% compared to the control group. There is mixed data on mepolizumab's impact on lung function and quality of life. Patients with an eosinophil count above 150 and recurrent exacerbation seem to be the most likely to benefit. It is generally quite safe, with rare hypersensitivity reactions as well as injection site reactions being common. Patients have been seen to develop shingles while on mepolizumab, and so there is a recommendation to consider vaccinating high-risk patients at least 4 weeks prior to starting therapy. This has less clear data on how long of a trial you should give before deciding whether your patient has responded, but guidelines are out there ranging from 4 to 12 months. Reslizumab, like mepolizumab, is also a monoclonal antibody that targets IL-5 to prevent its binding with the receptor. It is approved for add-on therapy in adults with severe uncontrolled eosinophilic asthma, leading to frequent exacerbations despite high-dose ICS and another controller. In its initial trials, an eosinophilic phenotype was defined as an AEC above 400, so that was largely the patients that were enrolled in its study trial. It is dosed at 3 mg per kg every 4 weeks, and it's the only one of the biologics today that is given IV. The infusion takes about 20 to 50 minutes to complete, and it needs to be given in a setting that is prepared to treat anaphylaxis as well as monitor symptoms for some time after the infusion is complete. Systematic review of 3 randomized controlled trials of reslizumab showed a 50% reduction in asthma exacerbations in patients with an eosinophil count above 400. And many other studies also showed significant reduction in exacerbations in patients treated with this drug. Some studies have also shown a significant improvement in lung function, asthma quality of life, and asthma symptoms. This drug also carries a black box warning regarding anaphylaxis and is only given in office. And response to treatment is assessed after 4 to 6 months typically. Benralizumab, which also blocks the IL-5 pathway, uses a different mechanism of action. It binds the IL-5 receptor on eosinophils and basophils, which not only blocks IL-5 from binding to the receptor, but it also triggers an antibody-dependent apoptosis, leading to a profound reduction in the number of eosinophils. It is approved in patients age 12 and up with uncontrolled eosinophilic asthma. Its first 3 doses are given every 4 weeks, and after that, it is dosed every 8 weeks, which can be very appealing to some patients, and it can be transitioned to at-home administration as well. In a multi-center trial of 1,200 patients with severe asthma, patients on benralizumab had reduced exacerbation rates by about half of those in the control group. The effect was much stronger when you stratified patients with an AEC above 300. Patients with an AEC less than 300 only had borderline significant improvement in their exacerbation, suggesting that in their exacerbation rate, suggesting that AEC is a predictor of a good response to therapy. But there are other trials that also showed significant reductions in exacerbations in patients with an AEC above 150 with multiple exacerbations in the past year prior to initiating the drug. There was evidence of improved lung function in some studies, but not others. Multiple randomized control trials have also shown an improved ability to wean oral steroids on treatment with benralizumab. The Zonda trial showed a median reduction of the dose by 75% with patients who were treated with benralizumab compared to only a 25% reduction in oral steroid dose in the placebo group. And the treatment group had a 4 times the odds of being able to reduce their steroid dose. In the meantime, these patients also still had a reduction of annual exacerbations by 55% despite being on lower doses of oral steroids. The adverse effects of this medication are very similar to the other drugs that we've discussed, and there is no black box warning. The last FDA-approved drug used for the treatment of asthma that is blocks IL-4 and IL-13 signaling. Dupilumab is a human monoclonal antibody that targets the IL-4 receptor alpha chain. And this chain is shared by the IL-13 receptor, and so dupilumab blocks both IL-4 and IL-13 signaling, which normally promote IgE production and mucus production and smooth muscle hypertrophy. It was just approved down to ages 6 and up for use in asthma at the end of this past October. And it is used for patients with moderate to severe asthma that have an eosinophilic phenotype or that are oral corticosteroid dependent. It has an initial loading dose and then goes on to maintenance dose every 2 weeks with a higher dosing option for patients who are oral steroid dependent or patients that are also being treated for comorbid severe atopic dermatitis. It is also approved for use in the treatment of chronic rhinosinusitis with nasal polyps. Dupilumab therapy was associated with a 50% reduction in the rate of asthma exacerbations in a multicentral trial that involved nearly 2,000 patients with poorly controlled asthma. Several trials have also shown an improvement in lung function in patients treated with dupilumab, especially in patients with an AEC above 300 or a higher baseline FeNO. In a trial of patients with steroid-dependent asthma that were then put through a scheduled taper, only 42% of patients in the placebo group were able to reduce their steroid dose compared to 70% in the dupilumab group. The dupilumab treated patients were more likely to reduce their dose by at least 50%. And even with these lower doses, they had fewer exacerbations. Injection site reactions are common. Up to 4% of patients treated with dupilumab had transient eosinophilia, with only a small number of these developing symptoms. And there are reports of various types of ocular inflammation in treated patients as well. So with all that being said, how do we choose which drug to use? There are no current head-to-head trials among these therapies to discuss or to demonstrate that any one of them is superior to the rest, but there are a number of aspects that we can think through to narrow down on what's a good fit for our patients. First, we need to consider their age. For a patient less than 18, rislizumab is not currently an option, and if a patient is less than 12, benralizumab is not an option. We also want to think about asthma severity. For reaching for these biologics for patients with moderate asthma, omalizumab and dupilumab are your options. For patients with perennial aeroallergen sensitization and high IgE levels, omalizumab is a great first choice of therapy. For non-eosinophilic patients, therapies that target IL-5 pathway show good efficacy, as does dupilumab. There are no head-to-head studies among these groups, but there are some network meta-analyses floating around out there that may show signs of reasons to use one over the other from these categories. Dupilumab is currently the only medication that is FDA approved specifically for oral corticosteroid-dependent asthma, but mepolizumab and benralizumab also show really good efficacy data in their ability to decrease oral corticosteroid doses in treated patients. We want to think about a patient's comorbidities to see if there are multiple conditions that we could maybe treat with just one drug. And then other factors that have a big play into decision-making are the administration details, whether it can be administered at home or in office, whether the patient is able to accommodate coming into the office frequently, IV versus sub-Q delivery, the dosing interval, which can be as frequent as every 2 weeks or as spaced out as every 8 weeks. And then the consideration of weight-based dosing of rislizumab, which could potentially offer more benefit to patients who are obese when they may not show as much response to the other medications with fixed dosing. We have to think about the adverse effect profile for a patient and discuss the risk and benefits. And then of course, a major limiting factor is the cost of the drugs and insurance approval. So usually between your phenotypic workup and kind of considering the combination of all of these factors and discussing with the patient, a first step in the treatment strategy often can become clear. And I just want to discuss a non-exhaustive review of other therapies that have been tried before for treatment of asthma. Despite the apparent success of blocking both IL-4 and IL-13 signaling with dupilumab, more selective anti-IL-13 therapies have not been shown to be effective in reducing exacerbation rates in patients with moderate to severe asthma. Ligelizumab, which has a high affinity binding to IgE greater than that of omalizumab, has also not been shown to be effective in asthma treatment. And then I also briefly want to mention other therapies that are in the pipeline. These are drugs that are focusing on targeting the alarmins, which you'll recall is quite a bit upstream in the type 2 inflammatory pathway. So these drugs are still in the trial period. Unfortunately, as far as T2 low asthma goes, there's a lot that we don't fundamentally understand about the mechanisms underlying T2 low asthma, and there aren't any biologics that I'm aware of that are on the horizon yet for treatment of those patients. And these are my references. And the word of the day today is monoclonal. Thank you for your time, everyone, and please let me know if there are any questions. Finishing quite a bit early.
Len's in Hawaii today, so if there aren't any questions, that's great. Thanks, Sana.
Thank you.